Hello, everybody. Thank you so much for being here for our third bicentennial year special lecture. My name is Barbara Bass. I know many of you, but maybe not all. And it's my great pleasure to be the Vice President for Health Affairs and Dean of the School of Medicine and Health Sciences here at GW. And I am so glad to have you here with us. Today, we have one of our own colleagues, and the special thing about this bicentennial lecture series is it's our own colleagues. It's not invited people. We got such great stuff here. Today, we have Dr. Stephanie Heiser with us, who's going to present the paper based on the proposal that she sent to us as part of the selection process for this lecture series. As before we get started with that, I want to remind everyone that this is, in fact, our bicentennial year. We are 200 years old, which is truly astonishing as a School of Medicine and Health Sciences. The university was founded a little bit before us, George Washington University, 4 years before us in 1821. But we came along just 4 years later as we were formed. Took that long to get our act together, to get the school formed back then. But that does mean that for 200 years, we've been training generations and generations and generations of talented and compassionate physicians, scientists, healthcare leaders in multiple professional disciplines, including our PA studies program, one of the oldest in the nation, physical therapy, occupational therapy, PhD studies, as in a variety of biomedical sciences, laboratory sciences, and a variety of other health disciplines. We got a lot to be very proud of for these 200 years. We are going to map them up next month, at the end of the month, because it was precisely 200 years ago, March 28th, when the very first student actually enrolled for a lecture at the then new medical school as part of the Columbian College of George Washington University. So it's a big year for us. We almost are beginning our third century, therefore, come April. And we'll have quite a ride ahead of us for that. As you know, we've had 4 lectures as part of this series. We've already had 2 wonderful lectures. We're going to have our third today. And then at the last of the month of March, we're going to have our 4th, which will be a duo led by 2 notable authorities in pulmonary hypertension, our new chair of medicine, Dr. Karen Fagan, who happens to be here, and Dr. Marty Gomberg, another professor of cardiology. But today we're going to have Dr. Heiser speak to us. And she sent to us a proposal entitled Early Rehabilitation in the ICU, Revolutionary Opportunities for Our Third Century. And that proposal was selected for presentation because it fires on all cylinders relative to what we hope to learn from each other in this bicentennial lecture series, showcasing the depth of talent that we have, as well as the many, many different disciplines that we support. Dr. Heiser is an assistant professor in the Department of Health, Human Function, and Rehabilitation Scientists. She joined our faculty in 2022 and has proven to be already a terrific collaborator among our faculty from multiple disciplines in our academic medical enterprise. It takes a team sport to get this work and research done. Her research focus, as we'll hear today, is improving rehabilitation in patients in the ICU and with critical illness. Dr. Heiser has published and presented her research in peer-reviewed forums, regionally, nationally, and internationally, while early in her career already building that trajectory as a rising star in her discipline. She received her BS in exercise science at Lipscomb University, followed by her doctorate in physical therapy at the University of Miami, and last, her PhD in clinical investigation at the Johns Hopkins Bloomberg School of Public Health. She's also a graduate of both the Johns Hopkins and University of Delaware Acute Care Residency Program and Critical Care Physical Therapy Fellowship Program at Johns Hopkins Hospital. She's an APTA board-certified cardiovascular and pulmonary specialist. So knowing that background, her lecture, which will be entitled Early Rehabilitation in the ICU, Revolutionary, got the GW thing going there, Opportunities for Our Third Century, and I really look forward to that. As I welcome her to the stage, it's my honor to present you with our Bicentennial Faculty Lecture Series Award. we are really glad to have you come forward and present your lecture to us. And we will have time for questions at the end, and of course, a reception thereafter. So thank you all for joining us. And without further ado, stage is all yours.
I'll snag the.
You want to keep this, I guess. Okay, there you go. All right.
It's okay. You can take my notes if you'd like. All right. Thank you so much, Dean Bass, for the introduction. Greetings, students, staff, clinicians, and faculty. Thank you so much for being here for this talk. I'm very honored to be giving one of the bicentennial lectures, especially on a topic that I'm very, very passionate about, which I think you guys will grow to learn as well. And so without further ado, we will go ahead and get started. So I do want to give a moment for those that are trying to get CEUs. You can either scan the QR code or text that activity code to the number that's posted up there. So I'll give a moment for that to occur. And this slide will also be at the end if you're just not quick enough on the draw to get your phone out. So it will be at the end of the slide deck as well. Let's go ahead and get started though. I want to start with a little bit of background as to why this topic is so important. So there's a growing number of patients that are becoming critically ill just due to our aging population with greater comorbidities. And as many of us witnessed over the last 5 years, due to the COVID-19 pandemic and those patients developing acute respiratory distress syndrome and ending up in the ICU. Advances in critical care medicine over the last 2 decades have improved survivorship. However, survivorship comes at a cost, with many patients experiencing new onset or worsening impairments in physical, cognitive, and mental health, collectively known as post-intensive care syndrome. Of note, these are not the only domains in which patients can have impairments after they survive the ICU. There can also be impairments in pain, fatigue, and joblessness. It's just the physical, cognitive, and mental health are the ones that are most widely studied to date. So let's take a minute and talk about what happens to the skeletal muscle of patients in the ICU. So about 2% of skeletal muscle loss occurs per day in patients that are in the ICU. In their first week of ICU admission, they lose about 15% of skeletal muscle mass. And then half of those patients go on to develop what we call ICU-acquired weakness. And we don't fully understand the mechanisms at play and the pathophysiology behind ICU-acquired weakness. There's still a lot of research that needs to be done in that area. However, early mobilization and rehabilitation potentially mitigates these impairments, specifically those physical impairments. We know that early mobilization and rehabilitation are safe and feasible, and there's a variety of interventions that we can use with patients that are in the ICU. And so the picture that's shown here is a picture where I'm progressing a patient that is endotracheally intubated on a mechanical ventilator, walking that patient in the ICU in the hallway. And so as you can see, it's just not me by myself, is it? There's a lot of other clinicians at play here. We have the respiratory therapist. We have a physical therapy tech. We also have the nurse that is helping to manage lines. So it really does take a whole team in order to do this. There's, aside from the variety of interventions, there's also differences in how those interventions are performed. So the timing of initiation, the duration, the intensity, all of those things sort of vary across the literature. And thus we have a bit of inconsistent findings in the literature regarding the efficacy of these interventions. And we'll talk more about this later on in the presentation, especially when we get into the gaps and challenges. But I want to just highlight that there is the inconsistencies there, and we need to do things to sort of try to address those. So I want to start with this landmark trial that was published in Lancet in 2009. This was the first randomized controlled trial that looked at the effects of early physical therapy and occupational therapy in the ICU. And what they found was improved functional outcomes at hospital discharge, decreased duration of delirium, and more ventilator-free days. The other thing that I want to highlight about this study, so again, take note of the year that this study was done, 2009. The usual care group in this study was not receiving any early mobilization or any rehabilitation. And that's a really, really important detail to understand when interpreting the literature, especially as the usual care has evolved over the last several years. A very recent study that was published in Lancet Respiratory Medicine just a couple of years ago, this was a single center randomized controlled trial looking at the effect of early mobilization on long-term cognitive impairments. And what they found was that there was a lower frequency of cognitive impairments measured via the Montreal Cognitive Assessment Tool at 1 year follow-up. This was really the first study to show an intervention having improvements on cognitive impairments after discharge. So as I said, we were going to circle back to those variety of interventions, and I'm going to show some pictures of some of those interventions that we can use in the ICU. And so this is a picture of neuromuscular electrical stimulation, and we use this to help to stimulate muscle contraction of patients where they're unable to elicit that muscle contraction on their own. And so we use electrical stimulation to try to get that muscle contract, especially in those early days when perhaps they're not able to facilitate their own muscle contraction. This is another intervention that we use with patients that maybe are too hemodynamically unstable to progress with mobility and getting out of bed. This is an in-bed cycle ergometer. This can be used for both passive and active cycling. And so there are published protocols that are out there and available to try to stimulate more active cycling of the patient if you use a sort of standardized protocol with it. And this is an intervention called functional electrical stimulation with in-bed cycle ergometry. So sort of combining the first two interventions that I showed. And what this allows is oftentimes I use this functional electrical stimulation and cycling with patients where maybe I'm doing the cycling and I'm seeing a little bit of active cycling and a little bit of activation of the muscles, but it's not sustained. And so I can use this functional electrical stimulation synchronized with the cycling to try to elicit more active range of motion of that patient. Oops, I went backwards. And then moving on to the last intervention that I'll just highlight here. So this is a tilt table, and this we can use to sort of progressively have a patient going into a weight-bearing position. So a great intervention for patients that are too weak to stand up at the edge of the bed, or if they are able to stand, it's only very briefly. So they're not getting those full benefits of weight bearing through their lower extremities. Whereas if you use this tilt table, we're allowed to progressively work toward them sustaining their weight bearing through their lower extremities. And also with this device, we can do other exercises in this position where they're supported. So we can do other exercises, we can do activities of daily living, so partnering with our occupational therapists to do co-interventions with these patients. So in 2018, the Society of Critical Care Medicine published guidelines around pain, agitation, and sedation, delirium, and immobility, and sleep disruption. These are often referred to as the PICS guidelines. And in these guidelines, they made the conditional recommendation that early mobility should be performed in patients that are in the ICU. And they based this off of, at the time, so they graded the evidence supporting that recommendation, and the evidence was sort of low certainty at the time of this publication. But what I want to highlight, and what I didn't get to add to the slide deck, was that just over the weekend, they actually updated. They did a focused update of these guidelines. And while the conditional recommendation didn't change, they did upgrade the certainty of evidence to moderate. So I thought that was a great thing to just add to this today. So the PICS guidelines are an integral part of the ICU Liberation Bundle. And so this is a bundle of care with components to try to improve the care that we're providing to patients in the ICU. And it's often also referred to as the A to F bundle. And so what those components consist of is A, is assessing pain and managing pain, B, spontaneous breathing and awakening, so trying to wake our patients up, get them breathing on their own, off the ventilator, the choice of analgesia and sedation, delirium management and assessment, and what I really want to highlight is early mobility and exercise. It is one of the key components of this ICU Liberation Bundle, and we really should be doing this. And then F is for family engagement and empowerment. And so when this ICU Liberation Bundle is implemented in its entirety, it improves so many outcomes, from mechanical ventilation, from death within 7 days during the hospital stay, physical restraint use, delirium. Also, it improves the likelihood of the patient being discharged not to a nursing home or a rehab facility. So a lot of positive outcomes just by implementing this entire bundle, where we're addressing the whole patient and not just specific components of the patient. So this is one meta-analysis that I want to highlight in today's presentation that was published in Critical Care Medicine in 2020, looking at the effects of rehab intervention on clinical outcomes in critically ill patients. And so they included 43 ICU randomized controlled trials with a variety of types of interventions. And what they found was that there was improved mechanical ventilation duration, improved ICU length of stay, improved hospital length of stay. And the treatment effect was greater in patients that had a longer ICU length of stay, as well as having a lower severity of illness. So how do we translate this evidence into practice on a large-scale implementation in our hospitals, in our institutions? And so this is a model that was published in British Medical Journal in 2008. I know the citation is old, but this model has been used at several institutions and has shown success. And so stage one of this model is really summarizing the evidence that's out there. This tends to be the stage that we're pretty good at doing. Like, we're pretty good at summarizing the evidence, knowing what we should be doing. And then we get to stage two, and that is where we identify the barriers within our institution or within our units. And we're also pretty good at identifying our barriers. Where things tend to get a little bit more challenging is how we systematically address those barriers so that we can not only successfully implement the intervention, but where we can sustain that intervention that we are implementing. Another key component of this model is measuring performance. I can't stress this enough, that this is a really, really important component with the implementation of any intervention on a large scale. Whether it's early mobility or something else, you have to measure your performance. If you don't, you do not know if you are successfully implementing what you think you're implementing. And you have to make sure that you're measuring that over time. And so stage 4 gets into this sustainability piece. And this is ensuring that every patient receives that same level of intervention. And this is a bit of a cyclic stage where we know that there is staffing turnover and new grads coming on. You constantly have to re-engage those individuals with mobility champions. If we're talking about early mobility here, which we are, we have to constantly engage new individuals. We have to educate, right? And then we have to make sure that we're executing this in a standardized way with checklists, with items on our rounding sheet so it doesn't get missed. And it can't rely on just 1 or 2 individuals being on the unit that day for the intervention to carry on and be sustainable. And then this brings us back to the performance measure. We have to evaluate whether or not we're actually implementing what we think we are implementing. So around the time that a lot of the studies after that 2009 landmark trial emerged, there were several other studies also that came about talking about the positive outcomes from early mobility and rehabilitation. And so a lot of institutions went to start to implement early mobility in their ICUs. And what they encountered were a lot of barriers. So we also started seeing a lot of literature come out around barriers to early mobility. And so these are just a few of those studies. This is a summary of the barriers. I'm not going to read through these all, but I am going to highlight a few of these. So there's a lot of barriers around the lack of awareness of a protocol, lack of guidelines, concerns around not just the patient safety, but the clinical staff safety. And there are protocols that are published out there and are available. There are guidelines, and there are ways in which you can ensure the safety of both the patient and the clinical staff if you are, following these protocols appropriately. The other key thing that I want to highlight here that is often a barrier is the communication, collaboration, and coordination with other staff. This really does take a team to do. As you saw in that first picture, it wasn't just me by myself. I had to have the respiratory therapist, the nurse, the physical therapy tech in order for that patient to successfully ambulate in the hallway on a mechanical ventilator being endotracheally intubated. So it really does take a team. The other thing that sort of I get a little disheartened about, but I'm a bit biased, as you could probably tell, is just the low prioritization and perceived importance of early mobility in the ICU. And I think we can see from the outcomes and what we see with patients and their long-term outcomes that this really is something important that we should be doing and is recommended by the Society of Critical Care Medicine. So there are a lot of publications out there with strategies and suggestions on how to overcome the barriers in your institution so that you can successfully implement early mobility. This is just one that I want to highlight because it was recently published in 2021 in Critical Care. And so it really, again, just to emphasize that it takes a multidisciplinary team, and you really have to identify the champions within each discipline, because it really takes those champions within each discipline to do that re-engaging and that educating that we saw in that model to really facilitate that sustainability of the intervention. And then using a structured QI process, we have to use structured processes in order for these interventions to not only successfully be implemented, but to sustain them over time. The other one that I wanted to highlight here is, adopting safety criteria. We do have safety criteria around early mobility, and I'll highlight that actually on the next slide. But before we move on to the next slide, again, going back to that ICU liberation bundle and making sure that we are addressing pain and sedation. It doesn't matter how much you want to do early mobilization in your ICU. If your patients aren't awake and if they're completely sedated, you're not going to be able to get that patient moving. You are not going to be able to get that patient walking on a ventilator. So we have to make sure that we're addressing all of those A to F components. And so this is a table from that PICS guidelines publication of safety criteria for starting and stopping both in-bed activity and out-of-bed activity. And I want to emphasize that these are guidelines. These should not be a substitute for your own clinical judgment. I can't emphasize that enough. So now we're going to get into a lot of the fun part, talking about the gaps in the current literature and considerations for future studies. And so we oftentimes in the PT program, we have our students reflect on like what they can do better, right? And we should also be doing the same with research. We should be looking at the literature with a critical eye and seeing what can we do better? How can we improve our clinical trials? And so this was a state-of-the-art review that I was a part of that was published just last month. So it's very new, hot off the press. And what we did was we looked at those gaps and challenges in the literature, but we did it from the PICO framework. And I know this is a small figure. I'm going to sort of zoom into each of these PICO components. But what we did was we looked at the gaps and challenges from the patient standpoint, from the intervention, the comparator group, and then also the outcomes. And so when we start to look at the gaps and challenges of the patient component of that PICO framework, unfortunately, a lot of our ICU rehab studies have made our results really not generalizable to most patients that come into the ICU. Most studies have really limited the eligibility of patients in their trials to patients that are completely independent at baseline. That's not the majority of the population that is in the ICU. And so we really need to figure out a way to navigate that, not only from the generalizability standpoint, but also that makes our sample size much harder to obtain when we are limiting our population to individuals that are completely independent at baseline. The other issue that we have with sort of the patient standpoint is with longitudinal studies, when we're really trying to look at outcomes at 6 months, 1 year, 2 year, and 5 years down the road, really getting at those post-intensive care related impairments, we need to make sure that we're doing things to retain those patients in those studies. Because often what happens is we lose a lot of those patients along the way to follow up, and that just ends up reducing our power for those results at each of those time points. So it's really important, and there are publications out there around strategies to really improve the retention of our patients in studies, and we really need to be adopting those, really thinking about that during the clinical trial design so that there's not pitfalls in the ability to retain our patients in our clinical trials. So when we look at the intervention, as you can see, there is a whole lot of gaps and challenges that need to be addressed from that standpoint. But I'll highlight a few, and then I'll actually circle back to this slide because a bit of my PhD work was actually along the lines of looking at some of these gaps. And so one of the questions that still is sort of out there in the ICU rehab literature is around the timing of initiation. And so we think that it's within the window of 48 to 72 hours of which we should be beginning our early rehab intervention and early mobilization versus sort of a later initiation. But still, the signal's not super strong, and we still need to do quite a bit of work to make sure that we are certain that it really is that 48 to 72 hour window that we should be intervening. Also, patients that are coming in for elective surgery and we know are going to have a short stint in the ICU, should we be doing prehab in order to prevent ICU-related harms and potentially mitigate any possible complications after surgery? The other challenge from the intervention standpoint is that many of our trials, the interventions stop as soon as the patient leaves the ICU. Well, then what happens once they get on the regular step-down units? Most studies have no idea. So in order to say whether or not our intervention is having an effect on a hospital discharge outcome or an outcome at 6 months, how are we to say that if we have no idea what sort of rehab they were getting when they were on the step-down units? So that's another big important question that we need to address. Either we need to continue our interventions throughout the entire hospital continuum, or we at least need to measure what patients are getting on the step-down units. And then the other big thing is looking at co-interventions. How is sedation and delirium and nutrition potentially modifying our interventions? And so there is a little bit of work that is currently ongoing looking at nutrition and early rehabilitation, but we still have a lot of work to do to see how sedation and delirium are impacting our early rehab interventions. All right, so circling back to that landmark trial from 2009, the first randomized controlled trial. So since that study, most of the institutions that have continued to do a lot of the early rehab clinical trials, those were the early adopters of early mobilization. They are really, really good at delivering early mobility and rehabilitation now. And they're still the ones leading the way with a lot of the early rehab literature. So what we actually end up seeing is not a intervention compared to no intervention group. We end up with a dose comparison. And do we end up with enough separation between the intervention group and the control group to really see a positive signal? And so that is one of the big questions that we need to figure out, is whether or not we need to define the control group so that we have a better understanding of what patients are getting in that usual care group. Same thing as with the intervention, we need to better understand how the co-interventions are affecting our comparator group as well. Then looking at our outcomes. There are a lot of different outcomes being used. The heterogeneity in the outcomes being used, the domains that are being looked at, as well as the different time points that are being looked at, there's a lot. And so there is a bit of work by a physiotherapist out of the United Kingdom, Bronwyn Conley, who is actually working on developing a core outcome set for ICU rehab. And so hopefully that will be published in the next year or two in order to improve the homogeneity in the outcomes that we're looking at, so we at least can have better comparability between studies and the ability to synthesize the data in those studies better. Additionally, along the lines of outcomes, we need to embed mechanistic studies in our clinical trials, looking at muscle biopsy outcomes, electrophysiology outcomes, to better understand what is happening on the cellular level, which we still do not have a lot of idea as to what is happening on the mechanistic side of things. So I said we were going to circle back to this slide and look at a couple of additional sort of gaps and challenges from the intervention standpoint. So during my PhD, a lot of my work was looking at how is the ICU rehab literature sort of describing the interventions and describing like the parameters of the interventions. And spoiler alert, not great. But we also don't have a good consensus on how to measure intensity, and that comes to light with some of the work that I've done. So during my PhD, I did a scoping review, and this was one of the questions that I looked at, was how are intended interventions described across studies providing early rehab in adult patients who are mechanically ventilated? And so we tend to do a pretty good job with talking about the type of intervention that we delivered, and the most common is progressive mobility. However, once we start talking about the different parameters, we see a great deal of heterogeneity. So when we look at timing of initiation, there's like 15 different descriptions for the timing of initiation. About a fourth of them, though, were within that 48 to 72 hour window, which is kind of the direction where we're heading as the prime time to begin intervening. But if you see the descriptions here of, say, within 24 hours versus after 24 hours, how do you compare those two studies? How long after 24 hours did they start their intervention? Unless those authors are being very transparent and also reporting like the mean or median of the average time that they started the intervention, we have no idea. And then when we look at the frequency of intervention, there are 8 different descriptions here. And the most common was once daily in the studies, and we did sort of lump 5 to 7, if the intervention was 5 to 7 days a week, into that once daily category, because we know logistically it is hard to deliver interventions on the weekend, right? So we gave a little leniency there. But one of the things I was really, really interested in was how studies measured intensity. And so out of the 148 studies that I included in the scoping review, only 29% measured intensity. So like how much patient effort is going into that activity or intervention within that session. Only 40% were randomized controlled trials. And even with the smaller number of studies at least measuring intensity, there were still 9 different descriptions of how intensity was actually measured. And most of those were actually muscle contraction, which actually goes back to the types of intervention of it being neuromuscular electrical stimulation. And that is how you dose that particular intervention. You're looking for a palpable muscle contraction. So with not a lot of guidance from the literature, Then my next question was, well, how do physical therapists in everyday practice figure this out? And so that led me to my next project of my PhD, which was doing semi-structured interviews with physical therapists across the United States, asking those exact questions of like, how do you determine the frequency? How do you determine the duration? How do you determine the intensity, which was always a fun question because the typical response was, oh, it was just based on the patient's tolerance. And that's quite a vague response at the end of the day. And so it took a lot of follow-up questions to really get to kind of more concrete data around that. And so the themes that emerged in regards to how physical therapists practicing in the ICU determine the intensity was really looking at a combination of factors. The tolerance based on objective data, so using that heart rate, respiratory rate, oxygen saturation, but there was still, a lot of the physical therapists did not mention any sort of cutoff of those values. And then also looking at patient appearance and their subjective response, so how they were reporting that they were feeling. And so this is just a little bit of the results from the study. This is a published paper in Physiotherapy Canada that was published 2 years ago for those that are interested. So let's bring us back to the GW School of Medicine and Health Sciences strategic plan and the pillars and the goals within each pillar. So there is some current initiatives at the GW Hospital and the clinical care pillar. So a whole multidisciplinary team is really working on revamping the nurse-driven progressive mobility program. And they're doing a great job, and we're working through some of those barriers and trying to identify them and systematically address them. And one of the things that we're measuring is the nurses' mobility documentation. So are those measures getting, like, are patients getting to a higher level of activity with nursing? The other thing that we're looking at is whether or not there's an increase in rehab consultation for patients that are mechanically ventilated. And so these are our targeted things that we're measuring our performance, so going back to that model of implementation that we're sort of working on. And then looking at future opportunities in our third century, so really fitting within the research pillar. And so this takes us back to the state-of-the-art review that I did, and we really left, there was a lot of gaps and challenges, as you guys saw, but we left the readers with these 4 sort of key questions that really was a question from each of those PICO domains, and that was, who should our target population be? How do we validly and reliably measure intensity? How should we define our comparator group or our usual care group? And what outcomes should we be looking at, and at what time point should those be measured? So with that, I will leave you with those provoking questions, and I thank you so much for being here, and I look forward to the questions. Thank you so much.
Really a terrific presentation, really, you know, as a past surgeon, an active surgeon who had more than their share of patients in the ICU, you certainly can see that just fading away almost by the hour when they're first, you know, immobilized. It's really a devastating thing. And the more you can do to keep them, get them back moving and moving even during those critical phases, the better. But it's really difficult, right? It's really, this is really hard work you picked to do, you know? So congratulations on tackling what is really a fundamentally, really critically important part of care for our most ill patients. So questions, anybody? Yes, I see one in the middle there. Could you, let's use the mic so that we'll record your question, please.
Hi, I was curious whether you had any useful outcome measures and whether those vary on the basis of alertness or sedation.
Like what outcomes to actually use to measure alertness and sedation?
Yeah, maybe more so clinically than for long-term tracking of outcomes after discharge.
Yeah, so I know what's frequently used is the Richmond Agitation Sedation Scale, which is a very easy tool. If you check out Vanderbilt University, they have a whole host of resources and training videos on actually how you can implement that like tomorrow. That would be a great resource for you, absolutely. And then along those lines, if you're also interested in measuring delirium, they have the CAM ICU that's also readily available on their site with training videos for all different patients. It's been translated into different languages. But yeah, a lot of great resources on their website.
Yes. And the pink. And then Dr. Fagan will follow.
Along those similar lines for the outcome measures, more so functionally, have you taken a look at the MRC sum scores at all in your research as it relates to ICU acquired weakness? And have you seen any trends with that?
Oh yeah, so for the Medical Research Council sum score, so that is typically the method of looking at whether or not someone has ICU acquired weakness, and what is reported in like the evidence as far as the diagnosis of ICU acquired weakness is having an MRC sum score of less than 48. And so there's a lot of evidence like supporting the use of that for that to make that diagnosis. And in fact, it's oftentimes better than some of the other ways of measuring it. Yeah.
Have you seen any implementation across disciplines? Because for those of you that don't know, it's a pretty simple assessment to do that could be across those different things. Have you come across any research like that or any plans in your own research?
That's a good question. So it really is an easy measure to implement, but again, you have to ensure within the discipline that you're training that there is good inter-rater reliability. So that's always a question, right? And so when you're doing clinical trials, you are going to have quality assurance processes where you are making sure that the reliability between your assessors is good so that the evidence that you're reporting doesn't have that as a limitation. Absolutely. Yeah.
Dr. Fagan.
Thank you. That was really a great review. When you think about the patients that responded in terms of their muscle strength and mobility assessments long term, were there any subsets of patient diagnoses that were associated with better long-term outcomes? I know you talked about how long they'd been in the ICU and things like that, but any diagnostic categories?
Yeah, great question. And this was actually, so I did a talk a couple of weeks ago specifically on post-intensive care syndrome impairments and sort of looking at the prevalence and incidences of each of those impairments. And like, there's a great meta-analysis by, I think it's Geens et al., that's published in Critical Care Medicine, looking at just that and the different types of ICU and how that impacts those long-term impairments. And so patients that have like elective surgeries and that have a short stay in the ICU, those often do much better as far as long-term outcomes. However, those that were admitted for like urgent surgeries, medical reasons, those tended to not do as well. They haven't looked at like very subsets of like specific patient populations. Actually, a lot of the ICU rehab literature has really been done in like the acute respiratory distress syndrome population. And so I can really only kind of speak to that, but hopefully in the future, there'll be more studies looking at those subsets of like specific patient diagnoses. Absolutely.
I think it's interesting because at least in the sepsis literature, where people are looking at long-term survivorships of sepsis, there's significant cognitive impairments, and there's evolving basic sciences, particularly in gram negatives, that are actually looking at like amyloid proteins that deposit in the brain during septic episodes. And I didn't know if there was a diagnostic criteria that would, especially with a cognitive impairment, which is obviously what the amyloid deposition may indicate.
Yeah, you're exactly right that is the other sort of patient population where we have a lot of literature on is the sepsis population, and we're also looking at like how can we provide interventions after those patients leave the hospital, and so there's actually a lot of like post-hospital bundles really targeting patients that survive sepsis in particular. But yeah, that's a good question, is specifically how, like what impairments those patients end up having, yeah.
Hi, thank you. That was a great talk. I have two questions that are a little bit more about like people putting this into practice, if I can. So it sounds like this has clearly entered the guidelines for care, and I'm curious first about if you have any sense of uptake, especially at potentially some smaller hospitals, community hospital type settings. You know, we all know that just because things make it to the guideline doesn't necessarily mean they make it to the bedside. And so if you have any sense of how commonly this is being done, and I guess as a second question to that, what kind of advice would you give about, let's say a patient is hospitalized somewhere where they're told this is not our standard that we're doing in our ICU, and it sounds like there's not necessarily a lot of data to help determine like incremental benefits of perhaps passive range of motion, which would be easier than some of the more complex, you know, things that you described. So, you know, would you have any advice about like advocating for patients who are in settings where maybe they're told this is not the norm there, but some incremental benefit could have?
Yeah, so I'll start with the first question in regards to like the accessibility in maybe like more rural areas, and that is a problem, and we know that, and oftentimes the barrier is like resource allocation, and like there's just not enough physical therapists and occupational therapists, and the nurses are sort of, you know, overburdened, like they have a lot more that they have to do in the ICU due to staffing. And so that we know that this is something that unfortunately is more prevalent in our, you know, teaching hospitals. And we need to figure out a way of making this more feasible and sustainable at those rural hospitals for sure. And perhaps some of the ways of navigating that is around, you know, trying to use safe patient handling equipment. Like if they can't perhaps invest in like a physical therapy tech or like another nurse assistant that's available on the unit, are there safe patient handling equipment devices that can be used to try to optimize what a person can do, maybe by themselves or just with the bedside nurse, to still make those things happen? And then in regards to your second question, like is there, in those situations in like those rural communities, is there a way to like advocate for your patients? And unfortunately, this actually happened to my own grandmother. She was in a rural hospital in Kentucky where there was no early mobility or rehabilitation. And so I was that advocate. And so I think the more people at least are aware that this should be happening and it is recommended by the Society of Critical Care Medicine, the more we get the word out, and family and friends know that if patients don't receive early mobility, like, you know, they're sort of set up for having potential impairments that, you know, persist beyond hospital discharge, then maybe we can sort of allow patient and their families the ability to advocate for themselves with the knowledge that they have that this is something that should be done regardless of what hospital that they're at. Yeah, great question.
Thank you for your talk. I'm wondering if there's any literature that talks about the consequences or impact on mental health after early intervention.
Yeah, so great question. We know that the sort of prevalence of mental health impairments after surviving the ICU is around like 20 to 30%. We sort of look at those mental health impairments from like specific diagnoses like anxiety, PTSD, and sort of depression. We know a lot of sort of the risk factors for each of those particular diagnoses. But we don't know quite the impact of like early rehab and mobility on the mental health impairments. What we do know, and this is something that is this is an intervention that is not early mobility or rehab that is being used in some institutions, is ICU diaries. Where not just the patient, but the patient's care team and family members write like what is going on each day, so that the patient can sort of go back and like read through and really process like what happened to them in the ICU, because it's so sort of fragmented what patients like remember, right? Because oftentimes they're intermittently sedated and like really not knowing what's going on. And so the ability to like read through those, you know, notes in the diary kind of helps them piece things together that, was really fragmented. But I think more needs to be done to maybe look at the impacts of early rehab on the mental health impairments specifically. Absolutely.
Okay, Dr. Davidson, do you have a question? Same question. Okay, there you go. Well, thank you so much, and really keep up the great work. And this is one of those examples almost of, you mentioned the cellular failures that occur in critical care all the way up through implementation science, clinical trials along the way. You kind of cover soup to nuts here, and it's a lifetime worth of work. So you have your work cut out for you. But thank you very much, and congratulations again on being one of our speakers.
Thank you.
Appreciate it.